The next case is 60-year-old male with pancreatic body tumor. The patient was referred from other hospital due to elevated CA99. CAT scan and MRCP revealed 36 by 24 mm mass lesion at the pancreatic body. The patient was scheduled for ESFNA for the diagnosis. The operator is Dr. Stefan Seewald.
Okay, so we are happy to welcome you here from the EOS suite, and I'm very happy to be together with Rob and with Ryozawa, because we have a very interesting case, and we also would like to discuss with you the strategy. So EOS always implies a strategy for the patient because we want to influence somehow the decision making for the patient. And you have seen in the pre-announcement, this is a patient. He has not very much symptoms. He had a little bit back pain, and from the laboratory results, he has no elevation of the lipase. The CA99 is a little bit elevated, but he has a lesion in the pancreatic corpus. And now our task is to show you first this lesion and then to describe what we should do, what we see, and if we perform an EOSFNA. So in such a situation where I know that the patient has a pancreatic cancer, the first question for me is always, does the patient has a bulging? And we have here introduced the EOS scope. I'm here just in the area of the pancreatic, in the area of the corpus of the stomach. And now I advance the scope here in the area of the lesser curvature, but we don't see any bulging. And the next point I usually do, I pass into the duodenum. In this case, I know the lesion is in the corpus, but I think it is always important to check the whole pancreas to get better information and a better overview. So there are different kinds how to perform observation of the pancreas here. I usually push the endoscope deep into the duodenum. On this way, we can have a short look of the papilla. If we see any irregularities, I think this is a normal papilla here. So I introduce the scope very, very deeply. And then Rob will help me. We will switch to endoscopic ultrasound. And then the first is what I'm looking for. I look for the aorta and the IVC for orientation, because then I know I'm at the deepest point, and in this area we also expect the right kidney. So I talk, when I'm here in this position, I see already the pancreas, and we are here now in the area of the pancreatic head, and now I'm first checking the pancreatic head, and I'm trying to find the bile duct and the pancreatic duct. This is usually the first I'm trying to do. So the tissue of the pancreas looks, you see the typical lobulations, and now the point is that I have torqued the scope a little bit counterclockwise. I use upward angulation. And now what is very important when you use the linear scope, you always have to torque the scope in that way, because when you use the linear scope, you don't see the whole pancreas at this level. So always what I'm trying to do is I torque the scope first counterclockwise until the pancreas disappears, and then I torque the scope to the clockwise also until the pancreas almost disappears, and then I know I have checked the pancreas in this at this level completely. So now, Rob, we will check if we find some typical structures here. In the area of the pancreatic head, we suspect the portal vein. And usually sometimes you can see the ventral pancreas, which appears a little bit echo poor. and the dorsal pancreas appears a little bit more echo-rich. I think in the area up near the transducer we have the ventral pancreas, and in the area below we have the dorsal pancreas. So next point, what I'm trying to do is to find the bile duct. Now I slipped off a little bit, and sometimes this is also a good example. When I lose the position, I always try to go in here into the duodenal bulb. Switch again back to the EOS image. And here I find very quickly back the pancreatic head. At the moment, here. So we are here now. We see very nicely here the pancreas. We see already the pancreatic duct in the middle. And now very nicely we are here at the moment in the duodenum. So the pancreatic head is now in the middle. And you will notice on the left side we have already a structure which appears relatively irregular. So this is already our tumor we can already see from the duodenum. Now I think what we do next is I measure the diameter of the pancreatic duct in the pancreatic head.
Yes.
We see here very nicely the duct. If we have any doubts, we can also use Doppler, but I think in this situation it's very obvious. So 2.4 centimeters, so there's no dilatation.
So Stephen, so may I ask a question?
Yes.
So in your country, do you usually perform EUS-FNA under general anesthesia or intravenous anesthesia? Like this case?
We usually use propofol for the sedation of the patient, and in Switzerland we have the advantage that we can use the propofol without anesthesiologist. So we have special certificate, the endoscopist, for using propofol, and most of the procedures we are performing with propofol. So now I'm in the stomach, and this is also a very interesting position, because here we see the superior mesenteric vein, and this is a very important position, because in some situations you can also see the pancreatic head from the stomach. And this is here, this position, because Rob shows very nicely where the arrow is. This is the pancreas, this is the vessel, and below is the pancreatic head, and above is the pancreatic corpus. And now I'm trying to trace the pancreas. The pancreas in the stomach goes a little bit up and to the left side. So I'm trying to pull out the scope a little bit, and you see my movements. I'm talking the scope clockwise, and while I'm retracting the scope. So this is the regular position of the pancreas. And here we see the lesion which appears here in the pancreatic corpus. And I think now we should more focus on the lesion. What we can notice here in this case, so the lesion is clearly circumscribed and has a clear border to the other pancreatic tissue. That is the first point. Second point is that the lesion has some cystic components in the middle that we have seen already in the computer tomography. The third point is the lesion is relatively big. It is about the tumor. I think we can measure now. I expect about 4 centimeters.
Stefan,
yes.
does this lesion has a relation to pancreatic duct? No, eh?
I will show you later. At the moment, the pancreatic duct is dilated. We have seen this already in the computer tomography. I will show you later, because I have the tumor here now very well, but the dilated duct I will show you later in the tail. And Now the question is a little bit when we watch the borders of the tumor, I think it looks a little bit like some minimal fluid also around in the upper part. There, this borderline here can be a little bit fluid because we have to get also a lot of information if the patient maybe has a peritoneal carcinosis, and if we have fluid, peripancreatic fluid around the lesion, this is also a sign for extension into the peritoneal cavity. And now we will
What
focus
do you
on
think
the
of the vasculature?
Yes.
Yeah.
Now we will focus on the vessels. In this area, we expect two kinds of vessels. It is the splenic vein and the splenic artery. And I think when we watch here at this vessel, there is, I think this is the artery, but there is no more interface.
So we can use, I think, pulse wave if you want.
Yes. Sometimes take picture. Okay. 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 It's a little bit.
Are there any questions from audience? If you have a
This one looks,
question, so
venous.
please
Venous,
hand the
yes.
What
microphone
about this
and
one over
ask.
here?
Wait a moment.
Yeah, this one.
Yes.
So that's
yes.
arterial.
This is the artery.
So this is artery, and then over here is vein.
So the artery is in most of the cases more close to the transducer, and the vein is more far. So there is no interface between the splenic vein and the tumor.
Yes. I
So
think it's a loss of interface, but do you think there is still a persistent interface with the artery?
I
do you
think yes. Well, maybe here in this area,
Close.
I push in the scope a little bit.
Yeah, maybe. Do you think in this area here, maybe?
So there's also in some millimeters. There's also there's also a loss of interface. So now I try to push the scope in because Nikos asked for the dilated pancreatic duct. So I
MRCP
push
showed
I push the scope more out. You see my movement is clockwise to get also the area of the pancreatic tail. And here, what do you think, Rob? I think there's some fluid around this lesion.
Some fluid
Yes.
here. Yeah.
So this looks already like an extensive disease, because this is also very important for our decision making if we have to perform EUSFNA. And now I show you, I think we will check this. This is a vessel, but actually I would love to show you also the pancreatic duct. We see here maybe the pancreatic duct in the middle of in the upper part of the tumor. And now I talk the scope, but here, maybe.
Why do you think that if you see the pancreatic duct within the tumor, perhaps that's important, but you think this is the duct here?
I suppose maybe we put some Doppler in.
Just an extension of the vessel, maybe.
Yeah. Okay.
I'm not sure that it's so important, though,
but
is
it's not important because only there was a question. But sometimes it is important when we have to trace a dilated duct and to see the dilated duct, and we trace the duct then to the area where the compression is. Okay. Now the question is how to proceed here. I think in this case, what we can summarize so far, this is a tumor in the area of the pancreatic corpus and tail. It is a large tumor, more than 3 centimeters, and we have signs of an advanced disease. First, we have no interface to the splenic vein. We have suspected no interface to the splenic artery, and we also have some fluid around the lesion, and we suspect already a peritoneal carcinosis. So in this case, I think it is surgery could be done, but first a laparoscopy in order to check for peritoneal carcinosis. But I think, and this we have discussed before, this is an extensive disease. And so I think histology, cytology in this case is important. What do you think, Rob?
So we discussed this. This is a local sort of regional phenomenon, but there is a chance with this extensive disease that this patient will be placed on a neoadjuvant protocol. And so obviously if you're going to administer chemoradiotherapy in a neoadjuvant setting, we must have a definitive histologic diagnosis. And I think there are some atypical features about this. Maybe the cystic areas are necrosis, which can be seen in regular adenocarcinoma, but it's also certainly seen in neuroendocrine tumors as well. So
the other point, what I was thinking, if this is maybe pancreatitis, but the patient has no history of acute pancreatitis, so I think the major solid part of the tumor is here more on in the area of the pancreatic tail. So I think if you agree, we would proceed with puncture. So when we perform a puncture from the stomach, so transgastrically, this is sometimes not so easy because we don't have such a stable position like in the duodenum. And I don't know what is your opinion. My favorite needle is a 25 gauge needle because the diameter of the needle is is smaller than from the 22 or from the 19 gauge needle, and I have less the problem of bouncing back during the puncture.
So the smaller the diameter, that's exactly right. The less rebound there is when you place it. But the diameter is also dependent upon what the pathology is in your institution. So we have in my institution rapid on-site cytopathology. So we would always go with a 25 because studies have shown that the tissue acquisition is the same. But if you needed to get a core, if you have only histopathology, no cytopathology in your hospital, then this would be the worst needle in terms of getting a core specimen. The bigger the diameter, the better the core. But I think with this, we will be able to get a good cell block, and we will also be able to get a slides. So, and it is easier to use.
Yeah. Now, when we perform the puncture, the best position for moving the needle is when we have a straight position. But this is sometimes not so optimal, especially when we have a hard lesion. And we also have to admit, when we puncture in the straight position, the needle goes out of the axis of the scope. And we have sometimes a problem with the transmission of the force. So sometimes it is better to bend the scope a little bit, because then you have the forces better in the axis of the needle. However, if the scope is too much bended, then you will also bend the needle and you finally have a problem. So somehow we have to find a compromise. And here in this situation, in the area of the stomach, sometimes we bounce back because we have a lot of space, and so the position of the scope is sometimes I perform a little bit inward pressure, and I put the scope here on my body to have a more stable position, because you will notice that we will have some problems in this puncture. The next point is now, for this puncture we use the 25 Procon needle, and this needle has also adapter for the length of the needle. And now here in this area it is very important that the needle is not very much out of the working channel because of the problem of bouncing back in this area. So I fix here the needle, my scope is in a relatively straight position, and this I always check before any puncture that the needle is definitely out of the working channel. Yes. Now I switch back, and now we try to get a relatively stable position. And now, what we have noticed before, this tumor has part of liquid components and there is more solid components. The solid components are here more in the area of the pancreatic tail. So my primary goal is to get in this area where we have more solid material. Now, what I'm doing now is I use a continuous suction. I do everything to get a stable scope position. Then I do slight movements here in this area to check if the scope is in a fixed position. And now I also use the big wheel. I do upward deflection. And then the next point is that I fix the wheel, because then I have again a more stable position. Now you see the blue dot. In this area my needle will come out. And now I fully open the elevator. Now I release the fixation of the needle. And now we will look how the needle comes out, and you see the needle is there, so the needle slips a little bit in this area. So what I'm trying to do now, the best is when I would get into the lesion tangentially. So first of all, we use now a Doppler to exclude vessel interpositions. Now I use the elevator, so you see the needle is now in the tangential position. This is a Procore needle, so this needle is automatically sharp. We don't need to sharpen the needle. And now, sorry, I will try to make, now I look for the movements of the patient, and you see the patient is breathing, and I try to puncture in that moment where the lesion is near the needle. So I'm sucking, and now so I'm in, but you see the needle is bended a little bit, but I think it is okay. We are inside the lesion. Now we are going to retract the stylet. And now I push the scope a little bit in. I know I have a more bended position, but stability is here the most important. So now we put some negative suction pressure, and now I'm trying to grab tissue, and now I do relatively forced movements, because when I'm too when I don't puncture with enough force, then the tumor may move and I don't grab material. So the important point is to grab material, and I also try to stay within the borderlines of the tumor, that I don't extend the needle beyond the tumor. So what I notice here, that I'm relatively fixed in the tumor. And now, Rob has mentioned this before, and Dr. Ryozawa, I'm now in one axis of this tumor, and now I try to get in other axes. So what I'm doing now, I go back, I release a little bit the elevator, and now I'm a little bit more up, and now I use more elevator, and I also use a little bit the big wheel. I push in again the scope, and I'm also getting now into another axis, but for sure we have the problem of stability, of keeping in the lesion. But I think...
Stefan, so may I ask a question?
Yes, for sure.
I asked the same question in Dr. Ryozawa's demonstration, but how many times do you usually puncture?
To be honest, I'm very happy that I'm in the lesion. So I try as much as I can, because sometimes after the second puncture, the needle is not that sharp like at the first puncture, and that's why I really try to go in many, many areas here of the lesion. I really try to grab tissue. But I think now, Rob, what do you think?
So usually the first pass is the best, as was mentioned. I think that again, I believe very strongly in the fanning technique that you must get different areas. But I think it's gone through, I think, many times. The only thing that I might have done a little bit differently is to avoid the cystic areas, because those are either necrosis. I don't think there's viable tissue there. But I think you've gone through many different areas, so it's okay now to.
The problem in this case is a little bit that if I go more in the area of the pancreatic tail, I have to retract the scope, and then I'm a little bit afraid to slip off. That's why in this case I had to make a compromise. Okay, now we will retract the needle.
So now we will go over and see what the specimen looks like.
Thank you. Yes. Awesome. So we have discussed before with the colleagues here. So okay, go ahead.
So we're expressing the sample. Anna is expressing the sample with the stylet. So this is the most controlled way to do it. We make the slides, and then we would put the rest in a preservative, in the cytolite.
So what we can see here very nicely that I definitely have material. You see here, these are some coagula, but here in this area you see whitish grayish material, and these are definitely cells. So I smear them off, and you see here also very nicely in the center, these are definitely cells. So we don't have the luxury of an on-site pathologist, but that's why we are doing like this, because this is a reliable marker that you have material. So we know we have a lot of material. So here you see very nicely the areas where are a lot of cells. We put this immediately in alcohol. This is very important for the cytologist. And now it depends a little bit on the cytologist. Sometimes we use cytolit to put in methanol for cell block. So our cytologists love the cell block. That's why when we have two, three slides with good material, then we put the other part, the rest, in the cytoblock.
So, Stefan, you will not repeat this puncture?
Yes. So we put this here.
Stefan, do you hear us?
Yes, I hear you.
Go ahead.
You are not going to repeat the puncture. I think that the question is how many punctures are you allowed to perform, to do? Because this said that 3 times puncture. Of course, if you inside the tumor, you can make many all the areas to take some material. But now you will not repeat all this puncture or not. You have enough tissue, no?
I'm not sure if I understood. We would probably do a second. Again, it depends upon your pathology situation in your hospital. We do have a pretty good specimen here, but I think for us we would do a second puncture. Would you not do a second puncture?
No, actually in this case I would not do, because I have really enough. And sometimes what I also do when I have this, give me the needle please, when I have the cytolit bottle, then I put the needle on the side and the nurse pushes the stylet inside, and then I also see if I have cells in the material we release, and then we shake, and then we have it in the fluid. Okay. So because we don't have the luxury of the on-site pathologist, but this is a trick we do to confirm that we have material. But in this, how to say, I'm here in front of the audience, and the pathologist will check immediately, but I'm relatively sure that we have material. Okay.
So if this lesion is invading the celiac trunk, then it would be non-resectable to our surgeons.
Okay, so then we will see later. We will check this for you, and then we
Congratulations,
get back.
Stefan.
Yes. Yeah.
Okay.
Yeah.
Thank you, Stefan.
Thank you very much.
Yeah.
So we will. Thank you very much. We will move to the next.